Hello, I'm Silviu Burcescu from Ensama Center, and I have a presentation, a very interesting one, about opioid addiction. And I will just give you some knowledge that you need to get a handle on this issue if you yourself are dealing with it, or other people that you care for are addicted to opioids. Now, let's start our story in 1756. Yes, I know. If we start in 1756, when are we going to get out of here? Well, have some patience. It's relevant for what we are doing here. 1756, Qing dynasty was ruling China. The emperor was not that happy because his Westerners were snooping around his empire for military secrets, and also he was concerned about the cultural influence that these Western traders have on the Chinese people. So he decided to limit all the trade with the outside world to Guangzhou port, somewhere in the Hunan province. This worked for a while, but it caused some ripple effects in the rest of the world. British East India Company was one of the main corporations involved with trade at that time. British East India Company is not to be confounded with its Dutch counterpart, the Verenigde Oost-Indische Compagnie, or VOC, a much bigger company. In fact, it had quite a bit of first in the world. The first multinational, the first mega corporation, the first corporation to sell stocks as a way to get investors to put money into the corporation. VOC was a huge company at its height. It had 1 million employees, and it ran a fleet of around 5,000 ships. So we are talking now not about VOC, but the British East India Company. So some quote-unquote wise men from the British East India Company, they thought how to respond to this, because they couldn't go too long by incurring losses in the trade with China. And they had the, against quote-unquote smart idea, to flood China with opium. Now, opium was cultivated in huge plantations in Benares in India, so they had a lot of it at hand. They put it into Guangzhou, and from there it kind of spread in whole China. 1767, this maneuver worked just fine. The British were selling 2,000 chests in China at that time. Not very sure how many pounds does a chest make, but I'm sure that it's a pretty big amount. Enough to start upsetting the Chinese rulers of the time. In 1799, the emperor decided to outlaw the use of opium, but this did not cause a dent in the use of opium. So in 1863, Dao Guang, the emperor of China at that time, decided to take the matters in his own hands, sent the emissaries to Guangzhou, and told the traders, the Western traders, to stop trading in opium and turn in all the opium stashes that they had. The Western traders, of course, ignored this demand, and the Chinese emperor practically put the city under siege. The British Empire sent the troops, and voila, we have a war. The first Opium War, which lasted 2 to 3 years, and ended up with China being defeated and having to concede Macau to the Portuguese government and Hong Kong to the British government. It started what the Chinese call the century of humiliation. So this opium, what is it? Why do nations go to war over such a substance? Now, opium was known to mankind since 3,500 before Christ. Opium is a derivative which is obtained out of a plant called the Papaver somniferum, or opium poppy, or just poppy. As opposed to marijuana, which is a plant quite unremarkable, but kind of a workhorse because it's very versatile, you can do many things with it. Papaver somniferum is a decorative plant. It flowers, and the flower is a really beautiful plant that you can see in traditional landscapes, in a lot of paintings, and it's even the official flower of the state of California. But its uses are not as versatile as marijuana. Practically, it has some role in the food industry. Everybody knows about the poppy seeds on the bagels. And by the way, if you eat the sufficient amount of those bagels, you are going to come up positive on a urine toxicology test. So be cautious, be easy on the bagels if you go for a test for a job application, for example. Now, of course, the poppy plant has a lot of utilization in medicine as well, but unfortunately is cultivated for illegal purposes a lot in the world still. So the plant, if you can imagine, it has a fruit or a pod that looks like a spherical, like a sphere with 3 to 4 inches in diameter. It has a color which can be described as white, pale green. If you cut that pod, the pod will ooze some kind of substance, latex-like substance, whitish latex-like substance, that when dries up, voila, you have the opium. So that's the opium. This resin that oozes out of the opium pod, and you can scrape it off and make opium out of it. Now, what is opium? Why is opium so desirable? All these people, the Mesopotamians, who were cultivating it in 3500 BC, passed it on to the Egyptians, who passed it on to the Greeks, who brought it into India and Persia. In fact, a name that you might recognize, Alexander the Great, was the one who spread the poppy into India, which became for a long time the main place on this earth where poppy plant was cultivated. Of course, not Alexander the Great himself brought the poppy seeds, but just his military expeditions kind of took products from Greece and spread them into the Far East. So the opium plant, the poppy plant, has been around for many years, for many thousands of years, and it had mainly a medicinal use. They mostly were cultivating it for its properties, for what it did to people. And we will get into this. For a long time, until 1803, nobody knew why opium does what it does. In 1803, a German pharmacist by the name Wilhelm Friedrich Adam Zerturner managed to isolate the active substance out of opium and called it morphine. Called it morphine from the Greek god of dreams, Morpheus. Yes, I know when I say Morpheus, you might be thinking of Lawrence Fishburne in The Matrix. And yes, apparently the Wachowski siblings who wrote and directed The Matrix did not choose that name at random. So it took another 30 years before the next most important component, active component of opium was discovered. That was codeine. These two together, they make a part of the opioids, which are called sleep-inducing opioids. They are the kind of opioids that put people to sleep. They kind of decrease the alertness, the level of alertness. There is also another category of opioids, which are called non-sleeping inducing opioids, like papaverine and tebaine, much less well known because they don't have an addictive potential. Now, the opioids are part of a bigger family called alkaloids. The term is also invented by a German, Karl Meissner, and it's a term borrowed from Latin, who borrowed it from Greek, who borrowed it from Arabic. Alkali means the ash residue that you get after you burn a plant. So plant ash, that's what it means. From this group of substances, there are other important from this group of substances, there are other important derivatives like cocaine and nicotine, two other addictive substances, but also purely medicinal substances like quinidine and atropine, and of course the big group of opioids. Another way to classify these opioids is by looking at how are they manufactured. The ones that are derived straight from the plant, from the opium poppy, are called the real opioids. Now there are semi-synthetic opioids. That means chemists took these components and acted upon them, tweaked with the molecule to a certain extent, and came up with a new generation called the semi-synthetic opioids. But the story doesn't end there. Chemists also synthesized other molecules which have no connection. They're not from the same family of substances, but they do the same things like the opioids, and therefore they are included in the opioid group, and they are called the synthetic opioids. Usually the synthetic opioids tend to be more powerful than the original opioids, and they were mostly discovered for medicinal purposes, but one exception is very prominent, and this is heroin. Heroin is diacetyl morphine, so it's a minor tweak to the molecule of morphine, the main ingredient of opium, which has two advantages in the eyes of the opioid merchants. One is it shrinks the volume of the morphine, and the second, it's a very liposoluble substance. And what does it mean? It means that it gets to the brain very fast. But heroin has a big disadvantage. It's a very short-acting medication. In fact, the half-life is 3 minutes. After that is changed into morphine and monoacetyl morphine, which are still active, and they will still continue to work up to an hour, and half an hour. Let's see, let's start with the beginning. If you made the stupid decision to inject heroin, what is going to happen? Within seconds, you start feeling a rush. It's a extremely enjoyable, pleasant feeling somewhere in the abdomen. And this lasts for only 1 or 2 minutes. And then you start continuing to feel a sense of indifference to boredom, decrease response to stressful situations, and a decrease in level of alertness. This lasts for another half an hour and an hour, and then the effect is gone. Now, a philosophical question. If it does make people happy, does create this rush, and after that a state of happiness, what is the problem? Why should we not just all go around injecting heroin? Well, to answer this question, you have to understand how the brain works. The brain has, in its evolutionary process, the brain acquired, let's say, somewhat of a rough inner compass, a compass that orients the individual to behave in a certain way that is beneficial for self and for the species. So the main, this inner compass, in order to communicate with the individual, has to give him a message that it's good what it's being done, and continue to do it. If not continuously, then at least repeatedly and with a certain frequency. And these behaviors that the inner compass considers beneficial for individual are eating and sexual activities for obvious causes. You're going to say that both of them in excess can be detrimental to the individual, and that may be the case, but in general it's very little dispute that these two activities are very useful for the individual and species, and the species, both the individual and the species, will practically collapse if people will not engage in these two activities. Of course, the pleasure centers doesn't respond only to that. It also responds to higher order pleasures, like other people expressing gratitude or admiration towards you, or physical exercise. That's a known way to trigger the pleasure center. And now we have the opioids or opioids derivatives who practically hijack the system. They just come into the system via the via the blood, and once they reach this inner compass, they trigger it. What is this inner compass? You have to imagine that when you talk about a device, you're not going to find something with a cover on it inside the brain. It's a much more subtle device that we are speaking about, but in essence it consists of two main centers. One of them is the ventral tegmental area, and the other one is nucleus accumbens. The VTA is in the midbrain. The nucleus accumbens is in the lower lobe of the temporal, lower part of the temporal, in the lower pole of the temporal lobe. So when the impulse starts from the VTA and gets into the nucleus accumbens, and from there in other areas like the frontal lobe or amygdala, the result is people reporting, feeling an intense pleasure. So that's the inner compass that I'm speaking about. Now the opioid components, what they do, they trigger this device with no reason. That means without the individual doing anything useful for oneself or for the species. And they do it by stimulating in a direct way the nucleus accumbens, but also by releasing the brakes from the VTA. So in two ways, they release the brakes from the VTA, therefore the VTA is free to discharge more electricity, and on the other hand, they stimulate in a direct way the nucleus accumbens. So that's in principle what they do. Why is it bad? Well, it's bad for two main reasons. One is it depletes the system. Any device, if you use it, overuse it, abuse it, then you are going to have a device that is not so responsive like it was initially. So it just leaves you after each use of heroin into a state of depletion of activity in the pleasure centers, which are experienced as a just miserable mood. And this is what forces people to do it again and again. Now, another issue is that the center, when you stimulate it at that level, at a massive level, because when you put morphine from outside, in fact, you stimulate these centers much harsher than the way they would have been naturally stimulated, you have a decreased responsiveness of these centers to the normal stimulants of the system. So you're going to have an individual for whom the regular joys of eating, having a partner, getting praise from other people, or exercising don't mean anything anymore. Why? Because they are used to the intense rash or intense stimulation that the chemicals are causing to his inner pleasure compass. Now, let's see what is the effect after that. So we established about the device, we established about how this device is accessed through the back door, through a loophole into the system, and we have this abnormal activation. But now, what does it lead to? Well, if you do that, of course, people are pleasure-seeking beings. They're going to do again and again what causes them to feel pleasure. And you develop what we call addiction or dependence. Now I'm going to make it clear what dependence means, because this is a very fuzzy concept out there in the society at large. But in psychiatry, we are very specific about what addiction means. If you want to diagnose addiction, you go about this way. You identify first a 12-month target period. It can be a target period that starts from today up to 12 months in the past. Or it can be any 12 months period if you want to establish if this diagnosis was present at a certain point in someone's life. So let's say that you want to diagnose in the present. You look at the period from today up to 12 months in the past. The first two criteria that must be met, and by the way, there is a list of 7 criteria, and 3 of them is enough to be met within this 12-month period. They don't have to overlap, but if they are present within this 12-month period, then you call yourself, you call that person a addict or opioid dependent patient. So, what are these manifestations? First, the first 2 are very easy to understand, very easy to explain. There's kind of no confusion about that. First, tolerance, and then withdrawal. Tolerance means that you need more to take of this addictive substance, let's say in this case opioids, to get the same effect. So you see that 1 bag of heroin is not enough After a week, you need 2, and after another week, you need 3, and after another week, you need 4, and so on. So you see this tendency to develop tolerance to the effects of the medication. And in fact, in heroin clinics, and yes, there are such things as heroin clinic, but only in Switzerland, where people are allowed to inject heroin under the supervision in order to avoid them going out there and causing a lot of disruption for the society. So in these clinics, people who are addicted to opioid, they have been injecting up to 300 milligrams without any respiratory depression, which would be a dose that would practically put into ICU any average person from the street. So very high dosages. You develop a lot of tolerance to very high dosages. Now, the other one is withdrawal, which is also very straightforward. Withdrawal is what happens if you abruptly stop the use of a substance, of an addictive substance. In the case of opioids, it manifests itself through perspiration or sweating and runny nose and tearing and piloerection or goosebumps, muscle twitches, nausea, vomiting, diarrhea. So if that happens when you stop, that means that the criteria of withdrawal is met. We have 2 other criteria which are kind of linked together. Increasing amount of time spent in activities related to getting the drug, being intoxicated with the drug, and recovering from the drug. So when you see this pattern over 12 months that you more and more time is spent in this kind of activities, you know that you have yourself the third criteria, and you don't even have to go any further, because at that moment you do have a diagnosis of dependence. But let's go further and see what is after that. Is kind of linked to the previous one. If you spend more and more time in activities related to getting the drug, being intoxicated, recovering from the drug, that means that you are going to crowd out other activities. And this is the 4th criteria, is crowding out of activities that used to be meaningful in the past. Spending time with the family, working, exercising, just socializing with friends. This kind of is crowded out. You don't do it anymore because you need your time to put into the drug-related activities. Now, the 5th criteria is use that goes beyond what you initially intended. That means this feeling of losing control. In the 12 months target period, you have to establish if there is this pattern of using more than you initially intended, more in amount or time. For example, you set yourself a certain limit. I'm going to do only 1 bag of heroin today, but at the end of the day, you do 3 or 4. Or say, okay, only Saturday I'm going to get high. But then when Saturday comes, you see that Saturday and Sunday and maybe even Monday, you were continuously using drugs. So this is a sense of loss of control. Now, criteria number 6 is continuous use despite awareness of the problem. So that means, is this situation where within 12 months the person can recognize that this activity ruins their health or other aspects of their lives, but they simply cannot stop. So continuous use despite awareness of problems. And finally, another related criteria is repeated failed attempts to stop. So again, it's linked to this concept of losing control. So within the 12-month target period, the person reports that they made several attempts to stop, but this was just not working out. Or sometimes it doesn't have to be an attempt in the sense that actually stop, but just this thought that you want to stop on repeated occasions, but not followed by any success. That means the 7th criteria is met. So again, this is dependence. You are dependent when you meet for the target 12-month period. There are 3 out of a list of 7 symptoms present. And these are tolerance, withdrawal, increasing amount of time spent in activities related to getting the drug, being intoxicated with the drug and recovering from the drug, crowding out of other activities like work, social interactions, time spent with the family, exercise, repeated attempts, failed attempts to stop, this feeling of having lost control, use of the drug more than what is initially intended, and finally, the continuous use despite awareness of problems. let's say that you decided to take that step and get into this use of opioids. I am going to predict the future for you. Of course, I'm going to bring statistics, and even if you are going to tell me, yeah, there are lies and statistics, I am going to reply to you that there are no better ways. It's not great, but there are no better ways unless you are a fan of reading tarot cards or chicken entrails or reading the coffee mug. I like to bring up a study that has been done in California because it involves a long period of time and also a large number of people. The California study followed 581 addicted patients to opioids for a time span of 33 years. So at the end of the 33 years, let's see what we have. Well, 241 only are still alive. That means a mortality rate of 50%, around 50%, 49%. What does that mean? You might say people die, so what's the big deal? 33 years is a long time. Of course, some of the people are not going to make it. Well, not so fast. 50% mortality rate means 50 times higher mortality rate than it should have been for that very same number of people if they were not addicted to the opioid. So 50 times higher mortality rate in that group. From the people who are still alive, what happened to them? Well, let's see. 20% of them were still addicted. They went on at it as if nothing happened, so still addicted. 40% of them, they were partially addicted. What does that mean? In kind of partial recovery. They were essentially not using drugs, but here and there they would relapse. The rest, 14%, were in prison. So these are people who did not make it out of prison, or they were at that point in prison. And then another 16% were squeaky clean. They were clean, but you know, cleanliness means that you are abstinent for a year at the moment of the 33-year landmark follow-up. Now, if these numbers do not mean much, let me put them into a little more colorful way. Let's say that you have 100 people coming at a wide mountain river, very rapid, very fast, very cold, and they think how to cross it, and they say, well, we are not going to go 10 miles upstream to cross the river on a bridge, but we are going to just go in the river and try to get on the other side. What happened out of this 100? Well, out of this 100, 50 of them, they will just die. They just sink to the bottom and they are carried to the ocean. That's done. That's said and done. From the people who survive, only 10 people are on the other side intact, still healthy, still okay. 20 of them are on the other side, but they are a wreck. They are so beaten by the rapids and by the stones that they are practically crippled. Another 7 of them are in the middle of the river on a stone, hanging on a boulder, still alive, but not quite out of trouble because they still have to do something about getting out of the river. And another 10 of them, you see them going down the river. They didn't sink, you see them, but they are just washed away. They're still in the river. And another few of them, you just don't know what happened to them. So that's pretty much it. Out of 100, only 10 are going to get on the other side in an intact manner. Another 20 are going to have some damage. And half of them, half of 100, that means 50 people are going to die trying to cross that river. Now, you have to ask yourself, are you going to step into that river if these are your odds of getting on the other side? Well, so let's see. Let's assume that you made this mistake, you stepped into the river, and now you want to be saved. What can be done to reverse this process? What is the treatment for opioid dependence? Well, obviously, the treatment will depend on what phase are you with this addiction. If you are already unconscious and barely breathing, then obviously you need a certain form of treatment. If you are intoxicated and want to quit, another form of treatment. You are already abstinent and you want to maintain abstinence, that's another form of treatment. So if you are unconscious, barely breathing, then you need to get to the ICU, clean up the respiratory tract, and be intubated, and an antidote must be given. It's either naloxone or nalmefene or Revex. They can reverse, these two substances can reverse right away the effects of the opioids and can resuscitate a person, bring a person back to life. Naloxone is a shorter acting medication. It lasts for about an hour, 2 hours, and nalmefene or Revex lasts for about 12 hours, 10 to 12 hours. So let's say that you are not in so dire straits as to need ICU treatment. You just want to quit. There are three options that you have. One is to stop taking opioids and just allow the withdrawal to take its natural course. What is that going to mean for you? If you use short-acting opioids like heroin or opioid pain medication, Percocet, Vicodin, Oxycontin, then you are going to start feeling the pinch of withdrawal around 12 to 24 hours after you stop. Within 48 hours, it will reach a peak, and after 7 days, it's pretty much over. If you use long-acting opioids like methadone, then your withdrawal will start after 2-3 days. It will reach a peak within 7 days, and you need another week. That means a total of 2 weeks, maybe even 3 weeks, to get completely out of the physical part of the withdrawal. After this physical part of withdrawal is over, you are going to deal with the psychological part of the withdrawal, which means cravings and a certain dysphoria. That means not feeling right, not enjoying anything. And this can last for a month or even more than that. So this is the natural course of the withdrawal. And while you are withdrawing, what is it going to happen to you? Well, first, you are going to feel miserable, either agitated, anxious, irritable. Sleep is going to be very difficult, if not impossible. You're going to see your flesh going with goosebumps all over the place. That's piloerection in medical terms. You are going to sweat like crazy. Sometimes your nose is runny. You tear up with no reason. You start having a lot of nausea and maybe even vomiting, diarrhea. So it's a miserable time. Sometimes it gets so bad that you need to go to the emergency room to be given some IV fluids to counteract the dehydration. So this method is okay. It's okay to choose if you are relatively young, relatively healthy. But it can become a problem in people who have cardiac conditions, or they are already debilitated by other illnesses like HIV or TB. Or just at an older age. That's when the withdrawal can become problematic. But in some countries like Singapore, withdrawal with no chemical support is pretty much the norm, is a policy, in fact. So let's say that you don't want the hard way, you want to get some relief, and what are the options then? You can do it either by using opioids or medications other than opioids. This process goes on in the medical detox, that means inpatient units, but it can happen as an outpatient as well. So what is the procedure? You are going to be given in an inpatient unit methadone, for example, up to 40 milligrams in the first day, and after that the methadone dose is going to be tapered off 25 to 33% every day. The whole process takes 5 to 7 days. Now, some programs prefer not to give methadone automatically, but to just give methadone only when there are blood pressure or pulse elevations, or maybe some other objective signs of withdrawal. And if you do not get them, then you just don't get any methadone, and you spend 3 to 5 or 7 days into detox until the worst of it is over. There is another way to detox without any opioids, and this may involve the use of medications like clonidine or Benadryl for sleep, or promethazine for nausea. Now, clonidine is a medication that stops the physical withdrawal. That means can alleviate the sweatiness, the goosebumps, the nausea, and the physical part of withdrawal. But it's not going to alleviate the psychological part. That means agitation, insomnia. There are other medications for that. As I said, Benadryl can be used for sleep, Trazodone maybe, Vistaril as needed during the day for anxiety, and in some people who would like, in some medical personnel who likes to take some risks for the comfort of the patient, the benzodiazepines may be used. So you are out of the immediate danger. You are already detoxed, so-called, detoxified, and now you are wondering what is next. Well, next is going to be a treatment based on two philosophical approaches. One of them is zero tolerance, and the other one is harm reduction. Let me speak about the zero tolerance. Zero tolerance means that you are striving to become completely abstinent. In that situation, you are going to either go to a 28-day program. By the way, the story of the 28-day program is like this. In 1800, a group of alcohol-dependent people, they got together and they figured out a way based on a 12-step recovery system to get out of the alcohol dependence. In approximately a century later, two alcoholics from Chicago, they took over and refined a little bit this 12-step program, and they invented the AA structure that persists even today, very, very popular in treating alcohol, but also other dependencies. In 1950s, the Hazelden Foundation took the same principle of 12-step recovery and molded a 28-day program which can be applied to any dependence, no matter what was the substance used. And since then, we have the system of 5 to 7 days detoxification, then 28-day program in an inpatient unit, and then there are a host of outpatient programs that can last anywhere between 3 to 6 months. There is also another form of treatment which nowadays is a little more rare than before, is the treatment community. It was this form of treatment was started in 1958 in California. The first treatment community was called Synanon, and it involved people actually living and working in a community, a little isolated from the rest of the society, and controlled in terms of the use of drugs. And this treatment can go on for 6 months or 12 months or even more. So this is the zero tolerance approach. Now there is another approach called the harm reduction model. The harm reduction model is like a capitulation. You just decided that you just cannot make it. You are going to be dependent, and you have the choice either to take it from the street or to take it from an institution that will provide it to you in a controlled manner. Now, the harm reduction programs are based on 3 medications. One of them is methadone, the most widespread. The methadone clinics are about 800 in the United States. They serve something like 200,000 people in the United States. They are spread all over the world as well. They have been proven to be effective in decreasing the criminality and decreasing the unemployment among opioid-dependent patients. Now, they don't do miracles. In fact, harm reduction and zero tolerance, they kind of claim pretty much the same rate of success, and rate of success defined as maintaining abstinence is really pretty poor. It's around 20%. But what the methadone maintenance programs claim is, and again claim with studies, is that they decrease the criminality and the unemployment among people who frequent those clinics. And this is not a minor result. The other substance that is used in this harm reduction model is LAM. LAM is a long-acting opioid medication that has the advantage over the methadone that it lasts for 2-3 days in your system, so it needs only 3 times a week administration as opposed to the methadone, which is daily. Both methadone and LAM carry some cardiac risk in dosages slightly higher than what is given routine. It can affect the QT interval that's on the EKG. There is a change that we call QT prolongation that can lead to a lot of arrhythmias and sometimes fatal arrhythmias. So finally, there's the buprenorphine. Buprenorphine is the latest substance introduced in the treatment of opioid dependence. It's the only substance approved for the use in private office. And the treatment is considered pretty safe because the risk of respiratory depression is very low with buprenorphine, even in overdose. It's what we call a mixed agonist-antagonist or partial agonist. It does stimulate the opioid receptors, but up to a certain level. And after that, no matter how much you take, you are not going to get any additional benefit. The buprenorphine treatment has to start once the withdrawal, some kind of mild withdrawal is already there, because being a partial agonist, it can precipitate withdrawal if taken too soon after the last dose of opioid. The dosages are usually 8 milligrams, above 8 milligrams. Let's say it's justified in some patients, but 8 to 10 milligrams are pretty much the maximum that you need to obtain a pretty good control of the withdrawal and the cravings for opioids. In closing, I'm going to discuss about a notion called codependence, because it's a very popular term. What does it mean? Codependence is used in different contexts to mean different things, but there are two main meanings. One of the meaning is this tendency of the friends and family of a person who has a opioid dependence to deny the existence of this problem, and also to refuse any kind of intervention to make it stop. Another meaning is the tendency of the friends or family of a patient who is addicted to opioids to protect that person from the consequences of the drug. That means pay the fines or look for another job if they lose the job, get them a lawyer if they are in trouble with the law, and so on. Codependency is important to understand and know about it, because it does nothing to help. On the contrary, it's very destructive when this attitude sets in the relatives of the patient with a dependence issue, and it just prolongs the problem, and because it's prolonging it, it has the likelihood to enhance the chances of a very negative outcome in that situation. Thank you, and I'll see you soon.